Welcome. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we will learn about the relationship between acid reflux and eosinophilic esophagitis, or EoE, in children from Dr. Erin Syverson. Dr. Syverson is an assistant professor of pediatrics at Harvard Medical School and an attending physician in the Division of Gastroenterology, Hepatology, and Nutrition, and serves as the director of eosinophilic gastrointestinal disease program at Boston Children's Hospital, a program dedicated to providing multidisciplinary care to children with eosinophilic GI disorders, or EGIDs. Dr. Syverson is passionate about advancing knowledge about pediatric EoE through research, medical education, and patient advocacy. Welcome.
Thank you, Jennifer. So happy to be here with you all today. Give me one moment just to share my slides for today. So great to be here with you all today. I'm honored to get a chance to talk to you today. I have been given the task of not only talking about EoE in children, but reflux and that overlap. So let's see what we can get through today. These are my disclosures. And the objectives for today, we'll be talking about EoE and acid reflux, first defining these two conditions, and then understanding the goal is to understand the overlap in presenting symptoms of EoE and acid reflux and better understanding how these two are related. I'm also planning on discussing how diagnoses for reflux and EoE are made, and then disease monitoring and treatment strategies. So let's move forward with clinical presentations. Starting with EoE, or eosinophilic esophagitis. Okay, so EoE, chronic inflammation that we see in the esophagus caused by allergy cells or eosinophils. In general, this is a condition that approximately 1 in 2,000 people, the prevalence has been rising. All ages of patient can be affected. We do see this more commonly in patients with other allergic conditions. That would be things like asthma, food allergies, and eczema. So EoE is a chronic disease, and it can progress if it's left untreated. In early stages of EoE, eosinophils infiltrate the mucosa or the lining of the esophagus. If this is left untreated over time, the persistent inflammation that's seen in the lining of the esophagus can give rise to fibrosis or development of scar tissue in the deeper layers of the esophagus. This can worsen over time and lead to a stricture or a narrowing in the esophagus. EoE symptoms can vary with age, and this is an important aspect to keep in mind, especially in our pediatric population. So in infants and toddlers, EoE can present more with feeding refusal, regurgitation, vomiting. As children get older, we might hear more specifically about abdominal pain or even heartburn. And then as we progress more toward our adolescent and young adult patients, we'll start to hear reports of what is thought of as to be more classic EoE symptoms or more esophageal specific symptoms like trouble or pain with swallowing or foods getting stuck, which we call food impactions. Notice here that regurgitation and heartburn span a wide range of these ages, which are two symptoms that are classically thought of as acid reflux symptoms. So what exactly is acid reflux, and how are these symptoms that we see in acid reflux different than what we're seeing in EoE? So what is acid reflux? So gastroesophageal reflux, or GER, G-E-R, or acid reflux is simply a description of when food or liquid that's in the stomach flows backward into the esophagus or even up into the mouth. Gastroesophageal reflux disease, or GERD, G-E-R-D, refers to when someone develops bothersome symptoms or damage to the esophagus in relation to reflux. So starting with our youngest patients, so reflux in general is very common in infants. This is due to a combination of factors, including immaturity of the lower esophageal sphincter, which is the muscle that opens and closes at the bottom of the esophagus, allowing food to enter when eating. Infants have a much shorter esophagus. They are on a full liquid diet and they spend a good amount of their time on their backs. So all of these things together makes reflux in this age group very, very common. Reflux in infants tends to peak in the first few months, around 4 months, as you can see here, and then gradually improves over the following 6 to 9 months. So prevalence of GERD in children. So now we're out of the infancy period of time. There's a wide variation in the estimates of prevalence in GERD in children and adolescents, with some studies reporting up to just under 40% having some GERD symptoms at some point. Symptoms with in 25% of patients on a at least once monthly basis and over 10% on a weekly basis. This is just in general. When you're looking at this kind of older children adolescent population, that rate is a bit lower in kids under 10 years and a bit higher in kids 10 years and up. There are risk factors that we think about that might increase one's chances of developing GERD. Those are things like a history of prematurity, patients with chronic pulmonary disease, including cystic fibrosis, esophageal atresia, or other esophageal motility problems, patients with neurologic impairments, neuromuscular disorders, Down syndrome, hiatal hernia, a patient with obesity, and a family history of GERD or GERD-related complications. When we think about GERD-related complications, there are some things that we see that are specific to the esophagus itself, sometimes outside of the esophagus. That can include things like erosive esophagitis, which we'll talk a little bit about in a few minutes. Peptic strictures, so developing and narrowing in the esophagus. Related to the inflammation. In adults, we can see development of Barrett's esophagus, which is a precancerous condition, or adenocarcinoma from chronic GERD. And then outside of the GI tract, you can also sometimes see issues with dentition, with dental enamel or cavities, or chronic pulmonary ear, nose, throat diseases too. Symptoms and signs associated with gastroesophageal reflux disease can both be GI related and non-GI related. So you might see here that some of these symptoms are ones we've already talked about for EoE, right? Chronic regurgitation, feeding refusal, vomiting, heartburn, trouble with swallowing. And then outside of the GI tract, some very non-specific symptoms in some cases, discomfort or irritability. In infants, we can sometimes see what's called Sandifer syndrome, where there's arching of the back or the neck. Sometimes you can see what looks like respiratory symptoms or upper airway symptoms with wheezing and stridor and hoarseness. In some cases, spells of apnea in infants where breath holding or where children stop breathing for a short period of time have been related to reflux. So as you can see here, now that we reviewed the symptoms, EoE and GERD are two separate conditions, but symptom overlap is very, very common when you go through each one. So let's move on to evaluation of these two conditions and how we can kind of distinguish this overlap. So in general, how is reflux diagnosed? The most important things to think about are getting a very thorough medical history and exam. So when I'm seeing a patient with symptoms that sound like reflux or the question has come up, these are the things I'm focusing on. I'm thinking about the age of the child and what symptoms are most common at that age, the pattern of the symptoms, and then evaluating for alarm signs. So you'll see here on the right side of the screen, we have a list of alarm signs. This is something I'm always thinking about as a gastroenterologist, just what is fitting the picture and what is not fitting the picture? What are the things that kind of set off alarm signals in my head to say, I need to think about this a little bit more. Maybe we need to evaluate a little bit more before we settle into one diagnosis. And then we think about a patient's medical history and some of those, as we talked about, risk factors that might increase someone's risk of developing GERD or other GI conditions. In the absence of alarm symptoms, a trial of an intervention is a next appropriate step in many cases. So big picture wise, this is kind of the way that we think about things. So we're obtaining that history and then evaluating for alarm signs. In the absence of alarm signs, you might try an intervention for someone who has symptoms that are classic for reflux, and then see how the intervention goes. If you back off on the intervention or wean off the medication, depending on what you've done, and symptoms return or they didn't respond to the intervention, that might be when you think about further evaluation, which can encompass a lot of things. So this is from a publication from 2018 from Dr. Rachel Rosen and colleagues, going through an algorithm for GERD evaluation for both infants and children. So kind of thinking about the algorithm I just set forth in the slide prior to this, going through a similar step scenario where we have a patient who's presenting with symptoms, we're evaluating for alarm signs, and if there are some, we're taking a different route. And if there's not, trialing an intervention. In an infant, that might be making modifications to feeds first, avoiding overfeeding, thickening feeds, and if no improvement, making a transition in what formula an infant might be taking, or making some changes to the breastfeeding parent's diet if the child is breastfeeding. And then if no improvement, this is at the point where a referral to someone like me, a pediatric gastroenterologist, would be useful. And if it seems that is not available, depending on where a pediatrician is practicing, could trial a period of a medication to see if that is helpful. Similarly, in older children, following a similar approach, if no alarm symptoms, lifestyle and dietary modification, which I'll talk about in a little bit, is a very reasonable first step, and then trialing acid suppression, and then seeing how things go. And if there's no improvement with that acid suppression, GI referral is appropriate at that point. So what other things might we think about when we're thinking about patients that don't perfectly fit into this kind of like reflux bucket? Someone who we have concerns for other possibilities, kind of reflux mimickers, if you will. What other diagnostic modalities might we use? So one consideration is doing a study called an upper GI series. This is a specialized kind of X-ray, patient swallowing contrast, and then X-ray is taken that highlights the shape of the GI tract, the upper GI tract, meaning the esophagus, stomach, and first part of the small intestine. This can evaluate for anatomic abnormalities that can mimic GERD, such as narrowing or strictures in the esophagus. Any blockages and emptying of the stomach, like a pyloric stenosis or a twist or abnormalities in the small bowel, which is called a malrotation. This test does not diagnose GERD. This is when we're thinking about evaluating for other possibilities that might look like GERD. So I think that's really important to distinguish. Sometimes when this test is done, the radiologist may be able to see some reflux of contrast back up into the esophagus that would support the possibility of GERD, but is definitely not diagnostic. Similarly, abdominal ultrasound is also a study that can evaluate for some of these possible diagnoses I just talked about. It also looks for structural abnormalities that could cause vomiting or abdominal pain. Not used for diagnosis of GERD, but something that might be discussed when a patient is first presenting with symptoms concerning for that. What about when someone is having symptoms that do seem like classic for GERD, but they're not responding well to medication? We'll talk about where this falls into the algorithm, but some of the testing I think is important for us to review is what is available out there to look to see what is happening when it comes to reflux symptoms. So esophageal pH monitoring is one approach that can be used. There's a few different ways to go about that. Classically, there's kind of one of the more older approaches or more conventional approaches. You can do something called transnasal pH monitoring. That's when we use a catheter that's inserted into the nose and is advanced down into the esophagus, and the catheter sits in place for 24 hours. There's sensors on the bottom of the catheter that can look to see how often acidic reflux episodes happen. So it actually monitors the pH of the esophagus. There are definitely limitations to this testing. It's uncomfortable for patients, right? They have a catheter probe in the nose for 24 hours. So some kids may not be able to tolerate that. And it also does not distinguish between non-acidic reflux. So you can have you can have stomach contents that reflux into the esophagus that are not particularly acidic, but are still irritating to a patient. This doesn't pick it up because it's just monitoring pH. And for that reason, also patients need to be off acid suppressing medication, which might not be possible for some patients. A similar study is the wireless capsule pH monitoring. So very similar approach, except you do not have the catheter in the nose. A little capsule is placed endoscopically, clipped to the bottom portion of the esophagus and stays in place up to 4 days. So can monitor changes in pH down there, but similarly cannot detect non-acidic reflux episodes and need to be off acid suppressing medications in many cases. So the kind of one step up from that is our esophageal pH and impedance probe testing. So similar to what I showed you in the last slide with pH monitoring, there's a thin tube that's inserted into the nose, advanced down into the esophagus, and it's left for 24 hours. But the difference here is we can actually measure non-acidic episodes because the impedance probe can tell when refluxate comes up into the esophagus and is not dependent on that change in pH. It can just tell when anything comes back up and can correlate between whether it's an acidic event versus a non-acidic event. All of these tests can be correlated with the symptoms that someone is experiencing so that we can go further to determine if what's happening inside in terms of reflux correlates with the symptoms that someone is experiencing. And lastly, just to talk about upper endoscopy. So in some cases, when a patient presents with symptoms concerning for reflux or red flag symptoms or the alarm signs as we talked about, we discuss moving forward with an upper endoscopy. So in an upper endoscopy, a patient is sedated, and we use a flexible tube with a very small light and camera on the end. The flexible tube is passed into the mouth, down the throat, into the esophagus, stomach, and first part of the small intestine. We can visualize everything in those areas and take pictures to look at. And we can also routinely collect small tissue samples called biopsies that can be looked at under the microscope by our pathologist to determine if there are any signs of esophagitis and what that esophagitis or inflammation in the esophagus might be caused by. That would include acid, but also allergic, such as EoE, or infectious, or complications related to GERD. Once again, this doesn't establish a GERD diagnosis, but is helpful to look for those complications and causes. So when might we consider an upper endoscopy or EGD? So going back to that algorithm, when symptoms fail to respond to acid suppressing medication or they relapse when a medication is stopped, this is when we as GIs might consider an EGD. Also, if a patient presents with trouble swallowing, painful swallowing, or history of food impaction, this might be an indicator to move forward with an EGD sooner rather than later. And that also paired with other considerations, right? Does this patient have a lot of other allergic conditions that might put them at higher risk for EoE? Or is there a known family history of EoE or family members who required esophageal dilation who might not know that they have an EoE diagnosis? So what might you see on an upper endoscopy? So when we do an upper endoscopy in a patient with GERD, the most common thing that we usually see is erosive esophagitis. So these kind of mucosal breaks that you can see down here where there's like a little bit of an irritation or erosion down here. The findings tend to be in the lowest portion of the esophagus, where just above the lower esophageal sphincter, where the esophagus meets the stomach, presumably due to damage or irritation that's been caused by acid kind of refluxing out of the stomach into the bottom portion of the esophagus. The severity of the erosions are graded anywhere from grade A to grade D by the gastroenterologist who's doing the procedure. In EoE, endoscopic findings tend to look a little bit different. We can see inflammatory findings and we can also see fibrotic findings. Inflammatory findings are the ones we tend to see earlier in a disease course, though there can be some variability patient to patient as to what early means. Those inflammatory findings that we see include swelling, white patches or exudates or furrows, deep grooves. So, and when you look at this picture over here, panel A is an example of a normal esophagus. The way I like to describe that is a normal healthy esophagus is pink, it's shiny. You can see the blood vessels coursing just under the surface of the esophagus, suggesting there's no inflammation. So when patients have edema or swelling, as you can see in panel B here, you don't see those blood vessels as well. Looks a little bit pale, looks a little bit more rough, not so smooth and shiny. In panel D, you can see the exudates that the arrow points to, where you see the white patches, and then furrows in panel E, which are those lines. They almost look like train tracks kind of running down the esophagus. All of this suggests inflammation that tends to be a little bit more specific for EoE. Those fibrotic findings, or fibrostenotic, meaning scarring and narrowing, tend to be seen more commonly in adults, though we can see it in children, and tend to be signs of more advanced disease. That includes things like rings, as you can see here in panel C, and strictures, which you can see here in panel F. As you see, even if you compare C to F, how narrowed F looks there, that's really much more narrow than we would typically expect for an esophagus. This is all helpful, endoscopically, to look at pictures and see. Oftentimes, many times we can step away from an endoscopy and tell a family, this is what I saw. It looks like EoE or might look like GERD. Sometimes, though, when we step away, it's not very obvious, these findings. So really, the biopsy is key when it comes to distinguishing GERD from EoE. And that's where the pathologists look at a tissue sample under the microscope, and they can evaluate for signs of inflammation. When we're thinking about EoE, we're looking for a certain number of eosinophils that they're counting in each field when they're looking under the microscope, and 15 or more eosinophils counted out in a patient with symptoms would qualify for a diagnosis of EoE. In patients with GERD, sometimes we can see some eosinophils, but we generally expect that number to be less than 15. And the reason is the way I typically think of it is eosinophils are a type of white blood cell. White blood cells are a sign of inflammation. So if you have some inflammation from GERD, it wouldn't be unusual to see a few eosinophils as kind of white blood cells in that area that have caused irritation. But you wouldn't typically are not expecting to see more than that 15 number. So that's really where we can help to distinguish the two diagnoses. So stepping back to that diagnostic approach, this is kind of the second half for the older children, right? After you've made a referral to your pediatric GI, if an acid suppressing medication has been tried and it either doesn't work or sometimes come back after you wean it off, we're moving forward with an upper endoscopy, as we just reviewed, and then we're looking to see what the results of that endoscopy are. If we are seeing signs of EoE, we're seeing erosions associated with GERD, we're treating, which we'll be talking about next. If we are not seeing any erosions, this is where our pH studies may be useful, to really try to help correlate what's going on with the patient's symptoms, that's causing their symptoms, despite not seeing any erosion. Because not seeing erosion doesn't mean you don't have GERD. We just don't have erosive esophagitis related to GERD. In a patient who's on a PPI and they're responding, meaning the symptoms are well controlled on acid suppression tends to be continued. But in patients who are having persistent symptoms and we're not seeing erosions on the scope, this is where doing that pH monitoring study or the impedance probe can be very helpful. So onto some more complex questions, right? What is the relationship between GERD and EoE? Well, as you've seen, these two conditions can coexist. Patients can have both as two distinct conditions. We're making that EoE diagnosis once you have an eosinophil count greater than 15, as I showed you, but you can have a combination of symptoms. There's also a relationship, because that's what we'll get into. We do know that some medications can potentially treat both conditions, so that's something to think about when you're thinking about optimal management. And then this hypothesis that's a little bit more complex, but I think is worth discussing, is that GERD could potentially contribute to the development of EoE and vice versa. So how would that happen? So as we know, two distinct entities, right? But it has been hypothesized, and there has been some data to suggest that the esophageal inflammation that's seen from GERD can potentially increase your esophageal permeability. What that means is when you get inflammation, that inflammation can make the cell junctions where the cells connect a little bit leaky in the esophagus in a way. So if you have increased permeability, then when a patient goes and eats a food, that those food antigens might be able to kind of get between those cells and cause more of an allergic response, kind of heightening the immune system's response to seeing those food antigens, therefore leading to EoE. And then we can think about this process backwards too, right? Patient with EoE has esophageal inflammation. When you have esophageal inflammation, it can affect the way the esophagus moves and kind of pushes foods down. It can also affect how that lower esophageal sphincter, how tightly it closes, and can be a little bit more relaxed. So more prone to stomach contents coming back up into the esophagus, causing GERD. Um, this is a depiction of kind of what I'm talking about when I kind of talk about the leakiness, right? The impaired barrier function in the esophagus. So acid exposure here can be irritating, can cause some epithelial, like some injury to the lining of the esophagus, so that you have some areas where food antigen can kind of sneak in and activate the immune system a bit, that then causes the recruitment of eosinophils and causes eosinophilic inflammation. So this is just a depiction of that process I was describing. So it's there's been some data to suggest this, but still a little bit of a working hypothesis. Um, Here we go. So let's move on to management. So overall, what are our treatment goals? I think whether we're managing GERD or EoE, important things, most important, improve symptoms, right? And for both conditions, that's the most important thing for patients. We want to make sure that the symptoms they've presented with, we're helping to treat them regardless. For EoE, we're also repeating biopsies to make sure that the symptom improvement correlates with what we're seeing on biopsies and on the scope, to make sure that inflammation is also improving, because sometimes they don't always correlate perfectly. In GERD, repeating a scope is not always necessary and very much depends on how a patient initially presented and whether they had a scope done in the first place and if abnormalities were seen. We'll talk about that a little bit more. In terms of GERD treatment options, as we reviewed earlier, first line, it's important to think about lifestyle changes and whether anything here may be contributing to symptoms. So for infants, that has more to do with reflux precautions with positioning after feeds and whether we can make any adjustments to feeds. And in children and adolescents, being thoughtful about the foods that can sometimes make reflux symptoms worse, and if weight management is appropriate, depending on the situation. Medications are a additional next step in patients, and they consist of antacids or acid suppressing medications like H2 blockers and proton pump inhibitors or PPIs. So I'd like to talk a little bit about these medications to start. So how does acid suppression treat GERD? This is a diagram of a parietal cell. So these are the acid secreting cells in the stomach. The purpose of this illustration is really to kind of give you a sense of where each of these medications are working. Antacids, which we'll talk a little bit about on the next page, that might be things you're thinking about, like Tums, Rolates, kind of your over-the-counter antacids like that. Are really just working to neutralize acid. I often think of it almost like as baking soda in a way, baking soda, how it neutralizes vinegar, right? So just neutralizes on contact, but is not doing anything to acid production in the stomach. Once it's kind of washed through the stomach, we have lost the effects of the antacid. H2 blockers and PPIs, on the other hand, are considered acid suppressing medications. So they actually change the way that the parietal cells produce acid. H2 blockers block the histamine H2 receptor here, and the PPIs block your proton pump right here that produces hydrogen ions. So that is where these two affect cells. So thinking about when you're making these choices, how are we using these medications? So on a scale of least effective to most effective, that's a huge generalization, obviously, but based on how these medications work. So you've got your antacids, that's like Tums, Alka-Seltzers, neutralize stomach acid, and they can be used short-term for symptom relief, but really are not going to do much in the long term. Your H2 blockers are medications like famotidine and cimetidine. These reduce stomach acid production, but not as effectively as your PPIs, which we'll talk about in a minute. And there is some flexibility in how you can use these medications. So there are some pros. While they're not overall as effective as a PPI, there's some flexibility with how you use it. You could use them, you can use them scheduled, or you can use them as needed because they tend to work pretty quickly. So they're fine to use as needed. On the other hand, your proton pump inhibitors or PPIs, this is kind of a list of ones that some may be familiar with. They more effectively block stomach acid production, but they need to be taken on a scheduled basis, either once or twice daily, and tend to not work well on an as needed basis. So when we're starting medications for GERD management, this is GERD specific, not EoE. We'll do that next. We might think about repeating a scope in some patients who had atypical sign or symptoms that we want to follow up on to make sure that we're on the right track. Someone who's having persistent symptoms, or if we saw damage at an initial scope and we want to follow up to make sure things are improving. Specific to GERD, the hope is that we can use acid suppression in short spurts in a way, right? Kind of complete a treatment course, which might consist of a few months, and then try to pull back on the medication or wean off of the medication and see if symptoms return. We do try to avoid stopping PPIs abruptly, specifically because you can get rebound acid hypersecretion. So it is preferred that these medications are tapered off of as opposed to just stopping. And patients who do have symptom recurrence after you've trialed withdrawing sometimes require longer term management. Pivoting to EoE treatment options, you're going to see some medication options that are similar, some that are different. So from a medication perspective, we have PPIs, which are also effective for EoE, swallow topical steroids or biologic called dupilumab, or you have dietary elimination. So let's talk a little bit about PPIs because this has evolved over the past decade or so. Prior to 2018, which were the updated consensus guidelines for EoE, a PPI trial was required for the diagnosis of EoE. Basically, a patient presented with symptoms, they had a scope, they saw that they had greater than 15 EOs on the eosinophils on the biopsies, and then a PPI trial was required for the next 8 weeks, and a repeat scope was done to try to distinguish between this concept of EoE versus EoE that was responsive to a PPI or PPI responsive EoE. This perspective changed in 2018 with the updated consensus guidelines, which made a lot of sense. And in the guidelines, they stated PPIs are better classified as a treatment as opposed to a diagnostic criterion. The reason for this was they found the patients who responded to PPIs with EoE and the patients that didn't respond to PPIs with EoE were essentially the same when they did more advanced studies, kind of looking at signaling pathways leading to EoE, and we're much different than patients with GERD without EoE, regardless of that PPI response. So since the change in the guidelines in 2018, a PPI trial is no longer needed, and PPIs are thought of as one of the 3 medication categories as an option for EoE treatment. Why is that? So PPIs, we're not using, in EoE, we're not using PPIs because of their antacid effects. We're using them because they actually have an anti-inflammatory effect in EoE. So PPIs block this picture that you see here, this is is what's called the Th2 pathway. So this is the allergic pathway that's overactive in a number of allergic conditions, including EoE. So what you see here is kind of is how food antigens can cause an inflammatory response in the esophagus, leading to eosinophilic inflammation in the esophagus, loss of that barrier function that we talked about, and in some remodeling, which means basically development of strictures or narrowing in the esophagus. So PPIs have been found to actually block STAT6 signaling, which is part of this pathway. And if we block this portion of the pathway, in some patients, we can block these things from happening. So that is why PPIs are effective in some patients with EoE. Now, not all patients with EoE, right? Depending on the study you read, anywhere from 30 to 70% of patients with EoE will respond to a PPI. And there's a number of factors to consider when you're making a decision about starting a PPI. But anywhere from the practicality of what formulations are available, capsule, chewable, liquid, to the fact that some studies have reported up to 40% of patients can lose response to a PPI over time. These are patients specifically with EoE. We also have to think about the side effects of medications. So immediate side effects are rare, but have been reported: headache, diarrhea, nausea, vomiting. And then long-term side effects. This is something that's important to consider and is being discussed more and more. Though many of the long-term side effects have a weak association or unproven causality. So this diagram here points at some of the things that have been reported in the literature, what PPIs may increase your risk of. I added the may in here because some of the data is just not very strong. But this is where I think it's very important to have a discussion with the family about the risks and benefits of a long-term medication, because unlike in GERD, when we're using a PPI for EoE treatment, this is a chronic treatment, right? Because EoE is a chronic disease. So when we're starting a PPI, we are continuing it without a stop date, without an end date, unless we're going to transition over to another medication or dietary management for EoE. But we know that this doesn't have a clear end point for PPI treatment, as opposed to when we're thinking about PPIs and GERD. A question that sometimes does come up is whether PPI can cause EoE. There was a study looking at some of the correlates between early PPI exposure and antibiotic exposure in infancy and in pregnancy and the development of EoE. And there have been a correlation has been seen between PPI use early on and development of EoE later on, meaning after 5 years. But there's many potential confounding factors. So something to consider, and something that we're always considering when we're thinking about starting any medication in a child, especially young children, is what are the potential downstream effects. There's a few different hypotheses why this might be the case. We know that PPIs can alter colonization of the microbiome, because it changes the acid content of what's going into the GI tract. PPIs might increase sensitization to ingested food proteins. And there has been some data to show that acid suppressant use in childhood has been associated with increased risk of other allergic conditions. So EoE being one allergic condition, there might be an association there. So data is not strong, but it is definitely a consideration, something to be thinking about. Just to briefly kind of cover the other medications that we think about for EoE, but these are not medications we'd be thinking about for GERD, right? Our swallow topical steroids for EoE. These have a higher efficacy, usually around 60 to 70%, depending on what study you're looking at. There's lots of different formulations available. And really, these medications work for EoE by coating the esophagus, so treating inflammation on contact, in the same way that you might use a steroid cream for your skin if you had a rash and you're rubbing that on the rash, or eczema. We're essentially trying to coat the esophagus or rub this on the esophagus to treat on contact. So lots of different formulations that are available, but there's lots of factors to consider there too, because many of these are used off label. So we have to think about preparation and what a patient might accept, whether insurance is going to cover what we are using, depending on whether it's off label or not, and then thinking about potential side effects, which are not common, but an important consideration and a discussion to have with your provider. Biologic therapy for EoE, right now there's one biologic that is available for EoE. It's a medication called dupilumab. It targets the source of inflammation that leads to EoE. So thinking back to that pathway we were just looking at a few slides back, it blocks a portion of that allergy pathway that leads to EoE development. And for that reason, it's also effective in treating asthma and eczema, and has a higher effectiveness than the other medications we've talked about. It's an injection that it's administered at home every 1 to 2 weeks, depending on a patient's age and weight. And lots of things to consider there too. And while it's very effective, we're always thinking about whether a patient's going to tolerate injections, allergic conditions that might also benefit from dupilumab. So could we get kind of a 2-in-1 approach in terms of treatment? And thinking about the side effect profile, which is relatively benign, but still is important to consider and talk to each and every family about, so everyone is on the same page of risks and benefits. And then to briefly discuss on dietary elimination, because I don't, this is an important consideration for EoE. And we did talk about diet for GERD, so I want to make sure we're giving the same attention, is that in lieu of medications, or sometimes in addition to medications for EoE treatment, we might consider removing one or more food groups from the diet that may be potential triggers for EoE. There's a variety of ways to go about this, varying from very limited diets where patients just drinking an elemental formula and maybe just a few fruits and vegetables, to 6 food group elimination, all the way down to a 1 food elimination. In these cases, there's a lot of discussion about, well, how do we decide what to eliminate when a family wants to do dietary elimination for EoE? Unfortunately, we don't have specific tests to identify the food. I wish we did. I always tell families I wish we had a test where we could confirm it was just broccoli and we take out broccoli and we're all done. But unfortunately, right now, that is not where we're at. So there are allergy tests out there, blood tests, skin prick tests. These don't really have a lot of utility in EoE management, unfortunately. So we base our plan for what we're going to eliminate based on what we know are the most common triggers in EoE in general, which is dairy, followed by wheat, egg, and soy. And then we're also a shared decision making with a family. And that's a really important thing to consider when it comes to dietary eliminations, is what other things are already limiting that child. Do they have other food allergies? Do they have celiac disease? Are they picky eaters? What does a child's growth look like, and how might this impact their growth and quality of life? And how might this impact how we're going to manage and monitor the disease going forward? And is everyone on board? Is the child on board? Are all caregivers on board? Because this is really something where no matter what household the child is in, needs to be followed pretty strictly to be effective for EoE management. So when families want to do this, I definitely make sure that we're pairing and teaming up with our dietitian to make sure that everyone is on the same page about how we're going to pursue dietary elimination in EoE. So taking a step back, some take-home points. So we know what we reviewed today is that EoE and GERD are 2 separate diagnoses. Patients may have one or may have both. And there's significant overlap between the symptoms of GERD and EoE, and really making that distinguish these 2 diagnoses, an EGD with biopsy is key. PPIs are used for the acid suppressing effects in GERD, and they have anti-inflammatory effects that can be effective in some patients with EoE, and it's important to weigh risks and benefits of long-term PPI therapy in patients with GERD and with EoE, using the lowest effective dose in both conditions, and trial weaning off periodically when we're using it in patients with GERD. So that concludes my talk for today, but I'd be happy to talk about any questions that have come in during my talk.
Wonderful. Well, thank you so much for your presentation and walking us through all the differences and variations and options available for each of the conditions. So the first question that came in, and for those of you joining us here, now's your chance. Go ahead and down there and click that Q&A box. Go ahead and type in your question. Um, the first one we've got in here is, are the EoE inflammatory findings reversible?
That's a great question. So, the inflammatory findings, so just to make sure everyone's on the same page, inflammatory findings that we see in EoE, right? We saw that the edema, right? The inflammation, the exudates, the little white patches and the furrows, and they are reversible with treatment, right? So one of those three kind of medication groups or dietary elimination. The fibrotic findings, which I think is important to note, right? Those rings and the strictures are also reversible, but are a little bit trickier to reverse because they're more advanced findings. And as you saw kind of in that cross section in one of my first few slides, they're kind of deeper findings. And I think of more as like scarring, in the same way that if you had a scar on your skin, it takes much longer for that to go away. So they can be a little bit trickier to treat, but all findings are reversible with intervention, with good, consistent, persistent intervention.
You talked a little bit about how there is a difference between GERD and EoE, but also how people can have both.
Mhm.
At what point, if someone has GERD, might a clinician look into the potential additional diagnosis of EoE?
Yeah. So usually what I'll do is if someone comes in with a classic kind of presentation of GERD, meaning say heartburn, right? Without a family history of EoE, without any other kind of red flags, trouble swallowing, as we kind of talked through with those alarm signs, that's when many times and like kind of our algorithm supports trialing some of those interventions with a medication or dietary changes. If things don't get better, right? Or if things get better, but then you try to wean off of that medication and symptoms come back, that's when I would think about doing an upper endoscopy to evaluate further. I might jump to an upper endoscopy sooner if someone comes in with symptoms of GERD, but they have a really strong allergic history, or there's a first degree relative who has EoE, or not only do they have heartburn, but the more I kind of pick through their history, it does sound like they have a lot of compensatory behaviors at meal times where they're chewing their food for a really long time. They're the last one at the dinner table. They're drinking a lot to wash foods down. Starts to send off little alarm bells that maybe we need to evaluate with an upper endoscopy sooner.
Thank you.
Mhm.
You also talked about how some medications for EoE are off-label.
Yep.
For those not familiar with the term, can you clarify what the term
Yeah.
off-label means?
Of course. So, off-label means basically we're using a medication for an indication, meaning like a condition that it hasn't officially been approved by the FDA for. In pediatrics, we do this all the time, unfortunately, because many times, kids get the shaft, which stinks, right? As the FDA has approved a medication, and then they're not going to go and do the further study in the pediatric population, but we're using it anyway. So EoE, our patient population with EoE has really kind of gotten the shaft for some time. And up until just recently, all the medications we were using were off-label, meaning not FDA approved. Not that we don't have good data to support their use, right? Many research publications out there showing that swallowed topical steroids are very effective for EoE, but up until last year, we didn't have an officially FDA approved medication for FDA approved swallowed topical steroid for EoE. So we've got a combination of things, and how that really plays into things in terms it can sometimes affect what insurance is willing to cover, really, and ease with which patients can get it and how much they have to pay out of pocket for medications.
Thank you. So let's flip that a little bit then. And so since we've talked about what's off label, let's then talk about what is approved. Can you
Yep.
clarify for our viewers in the US what treatments are indicated for EoE?
Yeah. So in terms of FDA approved medications for EoE, we have two. One is a budesonide oral suspension. That's the brand name is Eohilia. That was approved about a year ago for EoE. It comes pre-packaged in a little stick pack. It's commercially available, meaning that it's already prepared in the right formulation to coat the esophagus. We don't have to send a prescription to a compounding pharmacy for them to make it, or we don't have to tell families we need you to mix this up at home on your own. That was approved a year ago, and right now is FDA approved for patients 11 and older. And then dupilumab is the other FDA approved medication. That's a biologic. So kind of works at the beginning, a few steps of that allergy pathway that I showed you all. It's an injection, and that's approved for kids down to 1 year of age who weigh at least 33 pounds.
Thank you.
Mhm.
So some people are curious about things like that with, for example, the dupilumab.
Mhm.
What do we know about how effective it is after years of treatment? Are there
Mhm.
certain periods of time that people stay on it?
Yeah. So dupilumab was approved for EoE back in 2022. So a real world data, we've got like close to 3 years. That does not count the years that it was in clinical trials, which was much, much longer. And it's also been approved for other allergic conditions like asthma and eczema since 2017. And not many, but there's like a good chunk of those patients with asthma and eczema who also happen to have EoE who've been getting the fringe benefits of dupilumab during that time. Um, in terms of our long-term data, it's a combination of all that information that we have. Right now, the way dupilumab is being used is as a chronic medication, as we are with all of our other medications for EoE, right? So once we're starting it, there's no plan for a stop date. Um, in theory, just like every other medication, if we were to stop dupilumab, the findings of EoE would unfortunately come back. That being said, it's a newer medication, so what we'll find out in the next 5 to 10 years will be really interesting. Is there the potential that this medication could be disease modifying in some way, and change kind of what like our long-term views of EoE and EoE management? It's possible, but we don't have that data just yet.
Well, it dovetails nicely into another question that we had is, can people grow out of EoE? Like, is there
Mm,
a point where they don't have it anymore?
yeah. The rule of thumb is no. The caveat to that is like nothing is impossible in medicine, right? So if you go and kind of look at the literature, it's very, very unlikely. There's a small percentage of patients where it has been reported that they've outgrown it, but it's more the exception to the rule where that does happen.
We talked a little bit about some of the newer approved treatments and we talked about some of the longevity things. And so people are also curious, what are the long-term risks of PPIs?
Yeah, yeah. So that could be a whole webinar in and of itself. There's been a lot of reports of potential long-term side effects from PPIs. The way I usually phrase it to patients is we're always weighing that risk benefit ratio, right? The risk of having untreated or undertreated EoE and the potential development of strictures and what that might look like versus the potential risks, long-term risks of PPIs. The ones I think about more so, at least in my pediatric population, is how a PPI can affect um, like micronutrient and vitamin absorption. So I'm trying to be thoughtful about that in the setting of like an increased fracture risk or decreased bone density. So I like to make sure that all my patients are getting sufficient calcium and vitamin D in their diet. Um, I am also very thoughtful about the way that PPIs can affect the gut microbiome and the pH of what's in your gut, right? We have acid for a reason. Acid's good. Acid is good. Acid helps to break down food. It also is our first line of defense for any microbes that are entering through our mouth or through our respiratory tract, and we're swallowing them down. So when we're constantly suppressing the acid content of what's in the gut, you're going to get a little bit of manipulation of the gut microbiome. So can you be at increased risk for GI infections, potentially for respiratory infections, for patients who are at risk of aspirating little bits of GI content into the airway. So those are things I try to be thoughtful of, and I'm always considering a patient's medical history in that situation too, when I'm making decisions about medications.
Thank you.
Mhm.
So we've talked about EoE and we've talked about GERD. We've got a viewer today that's curious about, is there also relationships with Barrett between these two conditions?
Mm. The Barrett's association is related to GERD. There's been no documented association between EoE and Barrett's esophagus or any precancerous or cancerous conditions for EoE specifically. So that tends to be a more GERD specific complication in terms of Barrett's, and it is something that's worth monitoring and is something we try to. When you do an upper endoscopy, you can see signs of Barrett's. And when that is the case, then that changes our management and what we're doing with the PPI longer term.
Could you also, I think we've got time for like one more question. People
Yeah.
are curious also about triggers.
Mhm.
And so they're curious about kind of protocols around how to test for what those triggers are,
Mhm.
whether they be a food trigger or an environmental trigger.
Mhm. So I wish I had a better answer for this. The triggers are really tricky, right? At this point, we don't really have a great way to confirm what an EoE trigger is for a patient outside of removing it from the diet, repeating a scope and seeing what the scope looks like. Like our traditional allergy tests have just not panned out, like the skin prick testing and blood testing. There are some interesting things being studied out there, so hopefully I'll have a different answer for you in a few years. But there's nothing that's being used regularly in clinical practice that's really been able to give us great guidance for triggers outside of elimination of a trigger and then repeating a scope.
Thank you. Is there anything else you'd like to share with the audience? I know we've got so many questions. We've hit our hour, and so we really appreciate everyone's time. And perhaps, Dr. Syverson, we can follow up with you to look through some of those additional questions and do a follow-up blog post of sorts.
Yeah, of course. Of course. Yeah, there are a lot. I'm starting to scroll through them. So if there's any here that we should follow up on, I'm happy to do it. And no,
Wonderful.
I don't think anything additional to add. Hopefully this was helpful. And I could have talked about this for like 2 more hours. So if there's any follow-up, I'm happy to help. But thanks so much for this
Well,
opportunity.
absolutely. Well, thank you so much for sharing all your insights, and thank you everyone for asking such wonderful questions. I know we did not get to all of them today, so we will continue going those questions and look for opportunities to answer them. Thank you also to our education partners for their support of this webinar series, including Bristol Myers Squibb, GSK, Sanofi, and Regeneron. Our next webinar is about EoE treatment patterns and persistence. So please check out apfed.org/webinars and register for that next event on February 20th. You can also continue learning more about eosinophil-associated diseases by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In our latest episode, we talked with a patient advocate and a rheumatologist about eosinophilic fasciitis. You can find the episode as well as all of our episodes at apfed.org/podcast. You can also subscribe on channels like Apple Podcast, Spotify, Audible, and more. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again for joining us today for APFED's EOS Support Webinar Series. If you have a question that didn't get answered today, please email mail@apfed.org. Have a great afternoon.